All right, we want to welcome everybody to this week's edition of the Kentucky Pharmacist Podcast. We have no outside guests this week, so you just get the KPHA crew, myself, Taylor Williams, and Clay Snowden. There's been a couple of hot button issues that have popped up in the PBM reform and drug pricing space this week, so just wanted to get the group together to talk about a letter that came from the Kentucky Attorney General's office, signed by, I believe, 38 other AGs in the PBM reform space, and then take our first glance at President Trump's lowering drug prices action that he took yesterday. Kind of do a quick section by section review of that and get our team's insight on what we think that might be looking at over the next couple of months here. So Taylor, I guess I'll turn it over to you. If you want to give us a quick rundown of the AG's letter and what that might mean.
Yeah, so you're correct in your head count of 38 state attorneys general signed on to a letter at the beginning of this week that went to leadership of Congress, calling on congressional action regarding pharmacy benefit managers. So addressing majority and minority leaders of both chambers, and with signatures from attorneys general from all over the country, of both political affiliations, and just kind of taking a broad swath at the position of PBMs in the marketplace today. What I find really encouraging about this letter at this timing is that I think it's a little bit more stronger verbiage calling for more aggressive action or a more intense look at PBMs and the role that they play in drug pricing, patient access, and pharmacy operations in general than maybe some other previous letters or actions have done. So specifically, this group of state AGs is calling for action to prohibit common ownership of PBMs and pharmacies. And that kind of dialogue has been growing, taking place a little bit more frequently over the past year or so, I would say, at the state and federal levels. But seeing that position from a vast majority of state agencies across the country is certainly encouraging for potential future action, and really bold, really exciting, I think, for pharmacists to see right now.
Yeah, and we got some heads up that this may be coming, and the AG's office have reached out to KPHA to get our take on it. Obviously, we're very supportive and appreciative of Attorney General Coleman for his support on that. So essentially, right, it says if you own a PBM, you shouldn't own a pharmacy. Is that what their message to Congress is?
Yes, so sort of hearkening to legislation that has been introduced in last Congress and already in this Congress, I believe, and just an ongoing discussion that's even taken place, like I said, in some state legislatures as well.
Yeah, and for those that may not have seen it, I think it was Arkansas's House Bill 1150, I believe, passed out of both chambers and was signed. You correct me on the bill number there, but passed out of both chambers and was signed by the governor either late last week or early this week, doing exactly that in Arkansas. So once that bill goes into effect, a PBM shall not own a pharmacy or not be issued a permit in the state of Arkansas. So we're in a lot of support for that type of legislation. Clay, what do you think about PBMs owning pharmacies?
Yeah, so being the non-pharmacist on this call, it's a bit absurd to me, but I'm here to just ask questions. So I guess the question I have is, what is the initial, like, if this goes in, what's the next step? Like, what does it look like for independent pharmacies immediately and 5 years from now? And where does that, I guess, gap grow?
Yeah, so I think, not all, even in chain pharmacies, they're not all affiliated with the PBM. So if we really think about the whole landscape, primarily if we look at brick and mortar stores, it's CVS would be the most affected. I think it's my understanding that Kroger owns or is affiliated with the PBM as well. Like Costco also has an affiliation with the PBM. My guess would be those entities would probably get rid of their PBM and keep their pharmacy, but in the CVS world, who knows? Um, but essentially, we're looking at CVS Health would have to either close pharmacies or sell those off to some other entity. And CVS's message in Arkansas specifically is we're going to close all of our stores. I don't know that will happen or won't happen, but that was kind of the threat that they put out there. And the question is, if that happens, like A, you're going to have some access issues, but B, can the rest of the pharmacy community absorb all of that business overnight? The bigger implication, I think, on that is what happens, like from a mail order standpoint, because almost the vast majority of mail order prescriptions that are coming into Kentucky are being shipped here from pharmacies owned or affiliated by PBM. And those two would also not, from my understanding of the bill, would no longer be able to ship into the state of Arkansas. So I think my take, Taylor, I'd be interested to hear yours. Like, I think it's a good, like, we got to break down that vertical integration. But at the same time, we need to make sure that the access side is taken care of. Taylor, any thoughts from you?
No, I think you've really hit the nail on the head for the big picture pieces there. And in a state like Arkansas, and similarly in a state like Kentucky, with the rural areas and the rurality of most of the state, that we'd be looking at to see something like that roll out, and the aging and growing aging population that we have who may disproportionately be affected by a sudden change to their mail order prescription delivery. There would certainly be a need and some demands of the rest of our pharmacy community to step up and meet those needs and take care of those patients and help them figure out whatever their situation may come to be. To think a little bit long term and sort of the economic impact beyond that, like immediate logistical challenge. You're looking at a marketplace where your competitor doesn't know what you're getting paid potentially from an independent pharmacy perspective, and so it's this approach as a policy solution. Of course, you have to have some minimum reimbursement and other like safeguards as a baseline for it to be as positively impactful for independent pharmacies as it can be. But I think that this approach is really of interest to independent pharmacy owners, that this is something that catches people's ear whenever they've heard that it's happened in Arkansas, or that it is being seriously discussed at the federal government level. So there's some positivity and optimism around what that could mean for the long term, I think, is what they're really looking at.
Yeah, and I think I didn't do a very good job of answering the long-term effect, and you covered that well, Taylor. But I think at the end of the day, it's gonna have a huge economic impact on this in the state of Kentucky, right? Because I don't know what the latest number is, but there is a large percentage of prescriptions that are filled outside the state and shipped here from mail order pharmacies, and I think this is an opportunity to bring that business back into Kentucky. It's an opportunity to allow patients to go to a pharmacy that they choose, not to a pharmacy that was chosen for them based on the cost structure that their insurance company or PBM determined for them. So I think that is all the long-term picture view, and I think it's a positive one. I think it'll be some growing pains, if you will, in the short term to try to get there. So we'll see what happens.
Do you have an outlook or like any other perspective you want to throw out on the likelihood of congressional action based on this letter? Like what do you think that does for the chances that we see something like this move this Congress?
You're our federal expert in house, so
And
that's probably a better question for you. But I mean, no, I think there's a lot of focus, and I've said this before here recently. I think we've gotten to a point in DC where policymakers are saying, we know there's a problem, and now they're just arguing on how we're going to fix the problem, which is very much different than where we were even a couple of years ago when they weren't really convinced that there was a problem, that this was, just pharmacy complaining because they weren't getting paid enough. No, that's not the problem. We've been saying this and sounding the alarm for a long time, but it's gotten to a point now where they recognize the problem exists, and we just, is it this solution? Is it a payment floor? Is it, there are lots of options out there, which I think kind of transitions us to the second topic we wanted to talk about today, which is this breaking news on the executive order that's coming from President Trump. And I think, we can kind of just quickly go through it. It's brand new. It's not like overly, it's not too lengthy, but there's a lot of policy changes that are in here. So I guess if you want, can you give maybe just a quick overview of what your read on the executive order is, and then we can kind of break it down line by line.
Yeah, I think that there's been a high level or some high level like talking points come out of the White House prior to this point, um, emphasizing that they want the marketplace in pharmacy to be more competitive and trying to get some sort of um, grip around what all that looks like and all the players that exist, because it's a good deal more complex than maybe the lay person, an average voter even would think, an average patient would think within our world. So it kind of aligns with multiple angles of those talking points at making prescription medications affordable for Americans, and accessible for Americans to the greatest extent possible by the approach that um, this White House wants to take. They highlight some differences, and of course, there's the traditional finger pointing back and forth between administrations and the partisan switch, but um, kind of harkens back to a couple of common goals, just some maybe different ideas on getting there. I'm speaking very generally and vaguely because it's a lot of different um, ways to skin this cat, but all contained within that executive order.
Yeah, and I don't know how many sections there are, but I do think it'd be good to kind of just go through. Say there's 14 general sections, and kind of he's addressing a lot here.
Yeah.
I think the first thing they're looking at is the Inflation Reduction Act, which, I think the pharmacy community is broadly aware of it. It's portions of that are already in effect. So I think the first thing in section 3 is talking about potential changes to the maximum fair price provisions, which we remain somewhat concerned about because, yes, in general. So Clay, what they're doing is they've said for 10 drugs starting every year starting in 2026, there's going to be a significant reduction to the patient's out-of-pocket costs at the pharmacy counter. So, for example, if a drug costs $100 today, there's all these rebates that come in behind the scenes, and the federal government's trying to kind of get away from that in the Medicare program. They're saying the maximum fair price that somebody would have to pay out of pocket for that is, let's just say, $60. Sounds great. I think pharmacy in general wants patients out of pocket costs to be lower. But the problem is the way the system is set up right now, the pharmacy is going to have to buy the drug for $100, sell it for 60, and then hope that the drug manufacturer gives them the $40 back. That's the difference there. And best case scenario, we're looking at 3 weeks for them to get that $40 back. Probably look at 35, 45 days.
Yeah, so that was my initial thought here was, okay, how does a pharmacy, just in terms of bookkeeping and cash flow, like if I'm a pharmacist who's never had to experience this type of issue, what steps do I need to take, or where do I go for information? Is there resources that we provide that could be of help to anybody who may be experiencing this? And I'm especially thinking this when what we had talked about prior could lead to more scripts coming in that need to be filled, more prescriptions need to be filled. So now I'm potentially having a cash flow issue while I'm also filling more scripts. It sounds like as a pharmacist, there would be a lot of moving pieces there. And where do I go to get my guidance?
Yeah. Well, I mean, I think, we look at the national associations on a lot of that. NCPA on this particular topic has been putting out a lot of information. I think what I'm reading in this order, though, is that there could be changes coming to that, which we as a pharmacy community have asked for. We've submitted comments alluding to that they need to really address that spread or the difference in how that's handled. There are certainly better ways to handle that where the pharmacy is not cash flowing, having cash flow issues, holding that on their books as money due from, a multi-billion-dollar drug manufacturer when the pharmacy's barely scraping by. So I read this to be kind of a good thing that they're going to reevaluate that. They're asking that OMB kind of look at that problem, and they're going to come back, and that I think they have a timeline of 60 days for them to come back, which is timely because it's going into effect on January. That section also talks about there's a difference right now. A lot of the expensive biological drugs are not included in that program until 2028. They're trying to pull that forward to make that program available to all drugs, not necessarily just what we call small molecule drugs or typically just like pills and capsules, that type of dosage form. Taylor, any other thoughts on section 3?
No, I think you've covered that pretty well, and involvement of the Inflation Reduction Act can get really like complex with all the different players in the drug supply chain too. So good job summarizing there. And section 4 really is pretty similar too, in terms of the area it's addressing.
What do you think about section 5?
Getting back here, reading it in real time again.
So, I find this one pretty interesting. So section 5, they're wanting to publish a plan, and this is specific to outpatient prescription drugs that are dispensed by hospitals, trying to look at the true acquisition cost of those drugs. I'm guessing it doesn't mention the 340B program here, but I'm guessing they're probably trying to maybe get at that to see if moving to a model of a cost plus model, like that. Perhaps I'm reading into that a little bit, but that's basically what they're looking at, is looking at outpatient prescription drugs at health systems, what they're paying for and what patients are being charged.
That's what I took from that. That's what I took from that section too. I thought it was interesting that they allude to those sections of the Social Security Act as kind of the motivation for this section, and looking at how it impacts specifically Medicare patients. I think is an interesting question. And there are other parts of the executive order where 340B is specifically named. So I again maybe was reading into the hospital acquisition cost similarly to you, but certainly whenever we think of our institutions in Kentucky, I think that's pretty significant portion of those prescriptions may be dispensed at, under the 340B program and at that much lower acquisition cost. So
yeah, and I think and Clay, feel free to chime in on it with any questions or confusions that we may have skipped over. Section 6 is, I believe, primarily focused on Medicaid, right? So ensuring that Medicaid drug rebates and drug Medicaid payment methodologies are the most efficient and value driven. Be interested to see how they do that. So linking payments for drugs to the value obtained. That could be interesting. And they also want to support states in managing drug spending. So don't know what that will entail, but that could be of interest.
I had that same thought in reading section 4 that was very similar to section 3, but made mention of obtaining better value for high cost drugs. And I imagine that looks like assessing some sort of outcomes, but maybe interesting and or an opportunity for us to pitch the value that pharmacists provide, and monitoring and medication therapy management may be viewed as even more valuable as these objectives kind of come out. Just thinking from our profession standpoint and the service that we can provide, how we can pivot if drug spending and reimbursement changes, to showcase what pharmacists really are bringing to our patients.
That's a great thought. And that's something I hadn't really plugged into this, but that could come back. Section 7. So this is, I think, where they mentioned specifically 340B prescription drug program. So essentially, and if my read on this is, it's focused specifically on health centers, right? But essentially, health centers, in order to get their grants, they would have to. It's directing the secretary to determine basically how do we determine who is a low income, and some what their insurance looks like. But essentially, they would have to provide insulin and believe, is it epinephrine? Yeah.
Yes.
Insulin and epinephrine at the 340B cost plus a minimal administration fee for people that have a high cost sharing, have a high unmet deductible, or no health insurance. So trying to focus there again on increasing access to epinephrine and insulin.
I think that this topic area has been of interest again, both sides of the aisle, every level of policy making, state and federal. We've seen state legislation introduced by members of both parties, aiming to make these specific products as affordable and accessible for patients as possible. So that's seems to be pretty popular, and I am not surprised to see that as a 90-day sort of implementation directive, turning that around a little bit more quickly than some of the other initiatives within the order.
Clay, you're going to love section 8. It's the best section of the entire thing. Reevaluating the role of middlemen. That is the title of section 8. Within 90 days, they're going to figure all this out, right? Great. So basically instructing OMB director, secretary, a bunch of other people, recommendations to promote a more competitive, efficient, transparent, and resilient pharmaceutical value chain that delivers lower drug prices for Americans. How do I sit on that committee? I'm one in. I got some thoughts. So that is very vague and high level. And I think that's the part NCPA issued a statement today already on this, saying that they were the devil is in the details for how they started their statement. And I agree. We could go a lot of different directions with that, but remain hopeful that we continue to look into PBMs and the role that they're playing in market manipulation.
I think, and that's kind of a general point I made early in the conversation, but that's a very clear illustration of just how complex this is for the average American to understand all the different players in the marketplace and all of the different steps that it takes to get medication from manufacturing to the little green or amber bottle that you take home with you from the pharmacy. So interested to see what recommendations are provided to the president and how that's made public in the next 90 days.
Section 9 is it's pretty common sense. Let's increase how fast we can get generic drugs to market. Seems reasonable, right? They talk about biosimilars and generics. Trying to get those through the FDA approval process quicker. They also mentioned trying to improve access to over-the-counter products, which I think is another opportunity for pharmacists to assist patients as well.
Yeah. Well, and improving the process through which prescription drugs can be reclassified as over-the-counter, including recommendations to optimally identify prescription drugs that can safely be offered in that fashion. So I hope that there's a pharmacist on that committee too, or maybe several. But that's interesting to me too. Certainly some opportunities there, but maybe interesting to see what they're angling for.
Question for Clay. If you could pick one prescription drug and make it over the counter, what would it be?
That is actually a great question and a hard one to answer because there's so many great ones out there. But yeah, so I actually don't have an answer. But one thing that I did wonder about was if these drugs, and of course, I'm keep thinking about how our members who are pharmacists will be affected by this. What changes would that happen if certain drugs become over the counter? What if it is a drug that we get a high yield on for filling and that becomes over the counter? Or these drugs mostly things that pharmacists, in terms of just running a business, I'm thinking probably more independent pharmacy here, right? If I'm running a business, like, are these drugs ones that could be drugs that are making me a good amount of money that now become over the counter, and it could theoretically change cash flow?
Well, if you're thinking like an independent pharmacist, no drugs make you a lot of money, so that doesn't work. LOL. No, I think so. One of the downsides of moving things over the counter is insurance coverage. So especially commercially insured folks, they while oftentimes we see that decrease the list price of the drug because we get rid of rebates and all the things that happen behind the scenes with middleman PBMs and health plans. Decreases the list price, but now the patient's responsible for 100% of said list price instead of having a copay structure. Not as big of a deal in Medicaid because we see a lot of, in Kentucky at least, Medicaid will cover OTC drugs. But like using Narcan as the example, when it went over the counter, a lot of commercial insurance quit paying for it. And before they may have had a $0 copay on naloxone, but now it's $45, $50 over the counter. So, that's the downside. But prior to it going over the counter, any guess on what the pharmacy average acquisition cost on Narcan was?
I have no idea. Is it really low?
No, $150, $160. So that's where you see that the list price came down, but the actual cost of the patient in a lot of cases went up.
I gotcha. That makes sense.
It's interesting for that to kind of play into the whole Medicare Medicare D undertone of some of the earlier sections, and the fact that Medicare D doesn't often cover those over-the-counter products. I really am curious to see what, like, any data on that and accessibility, how much those list prices come down if there are some target drugs that our seniors may be using a lot of, that you're shifting spend away from Medicare, but then our patients ultimately paying more or less whenever you see that list price decrease. Could be
Yeah,
just kind of an interesting numbers game to follow.
yeah, that's a good angle. Like, are we trying to move the spend out of the Medicare program? But ultimately, you're shifting that to the patient that's having to buy that over the counter. Something to consider advocating for us. Maybe if we're going to move to that model, that Medicare start to pick up some of these OTC drugs. Um, Section 10, that's going to get some media attention.
It is.
What's Section 10 do?
Section 10 is titled Increasing Prescription Drug Importation to Lower Prices. So this is another 90-dayer. The Secretary and Commissioner of Food and Drugs shall take steps to streamline and improve our importation program under the Federal Food, Drug, and Cosmetic Act to make it easier for states to obtain approval without sacrificing safety or quality. So a little bit of vagueness in that language, but obviously a top of mind consideration for pharmacists, especially with some recent news in our drug supply chain. Knowing that there would be some increased importation is interesting, and then it's also, like, you think back to times of the pandemic, the supply chain issues that we had, the reliance that we already have on importing a lot of prescription drugs, the minimal, if any at all, manufacturing of even like antibiotics within this country. Yeah, it's a little bit surprising to me to come out of this White House too, but I might be thinking short-sighted there.
Yeah, I mean, we've heard the administration say before, and I think you hear it out of, a lot of folks, like, oftentimes the same drugs that are manufactured at the same go to another country and the list price is just, a fourth of what we're paying in the United States. And I think that's kind of what they're trying to get at, but something we definitely have to watch as the association and as the profession, and just ensuring the quality of those medications remains appropriate for our patients. So we'll see. I think Florida is the only state that has a pathway right now that would make this, that they could stand this up if it were legal pretty quickly. But I would anticipate other states jumping on, and I know Colorado, I believe, is probably close behind them. So we'll see, but something definitely worth monitoring. You got a high overview of Section 11.
Reducing the costly care for seniors. So this one, we're getting into some of the 180-day territory. So some maybe longer term action anticipated, just reading into those timelines a little bit and maybe priority level. But proposing regulations to ensure that payment within Medicare is not encouraging a shift in drug administration volume away from less costly office settings to more expensive hospital outpatient departments. So making sure that patients aren't being incentivized to go to any certain side of care that is ultimately costing Medicare more. The fact that it's the expensive hospital outpatient departments they're referenced, do you see that as looking at anything other than like an emergency department? Or, I don't know,
I do.
like
I
hospital
think
affiliated
this is
outpatient.
pointing towards, and I'm not the expert by any means on site of care regulatory regulations, but what we do know is that you can go to, say, an office to get an administration or an infusion of a product. But we see oftentimes those offices are owned by a larger health system. They steer those patients to an outpatient infusion center or something like that to increase the amount that they get reimbursed to provide that. I'm guessing that has something to do with, like, maybe there's a happy medium where we increase the physician office, maybe lower the outpatient infusion center reimbursement or something along those lines. That's my guess and take on that, but I don't know for sure.
Yeah.
Section
Well, how excited
12.
are you on section 12? Yeah.
I like that one too. They should have put that by section 8, but believe it or not, Clay, PBMs take money and they don't tell anybody where they put it. They say they don't do that, but they do. So looking specifically, we talk about ERISA a lot, and it's like the most, if you want to throw some confusion at any policymaker or any pharmacist or anybody, just, it's ERISA. It's ERISA exempt. It's, you can't do that because of ERISA. What the heck is ERISA? Well, basically, what this is outlining is that now the health plan has to have insight into what the PBMs are keeping for themselves. So any direct or indirect compensation received by PBMs has to be reported back to the health plan if it's an ERISA self-insured plan. That's my take on it. Taylor, what do you think?
Yeah. If I'm an employer sponsoring a health plan for my employees, I'm also pumped about this. Just a little bit more transparency, clarity around what you're paying for, why you're paying more from year to year, what just where that may be going, and what that's getting your patients in terms of actual healthcare delivery, access, and outcomes. So I was excited to see this kind of tying into the PBM reform note that we started the call on as well.
It's always fun to listen to PBM advocates skirt around the fact that they don't know anybody in fiduciary duty and why it's bad. If I have to tell you how much money I'm keeping, they do a decent job of trying to sell that method. But if anybody's telling me I'm taking a bunch of money from you, but I'm not taking any money from you, don't look. That's probably a bad thing, right? So hopefully this increases transparency there. And then we'll end with section 1314, just general provisions. But we can't. What a better way to end than hating on the drug manufacturers a little bit. So it looks like they're calling for some listening sessions and opportunity for the general public to report on recommendations to reduce anti-competitive behavior from pharmaceutical manufacturers. And, we'll see what happens there.
I'm interested in that group consisting of the DOJ, the Department of Commerce, and the FTC, all kind of coming together on that issue of anti-competitive behavior. There's been a little bit of uncertainty on some of their other investigations and reports as of recent, but excited to see this directive for those three groups to collaborate, and also kind of seems to tie in with the accelerating approval of generics and that kind of initiative and interest of the administration.
So we're way over time. We try to keep these at 20 to 30 minutes, and the recording currently says 44. So I guess if we can, as we wrap up, like what do you think pharmacists need to be doing, or what's our plan as an association to respond to this, and then we can wrap up from there.
Yeah, all in all, I think that we can take away a pretty positive, supportive, optimistic feel. There's again a lot coming out of this administration from day to day, so I think just keeping a close eye on within these 90 days that we should have some deliverables out of this order. They're coming from several different departments and just areas of federal government, so we will be doing our best to keep a check on all of those, see what sort of accountability there is for all of that to be delivered, and what really it's kind of a waiting game to see what regulations and policies come out of these discussions that they're starting in essence.
Awesome. I agree. It's going to be a busy couple of months. We've kind of been waiting for some big policy implications to come out of DC. I think this is the first of likely more. I think Congress is going to become more active because of this. It seems like all of these things again are just really kind of bubbling their way to the top of the stack. So we'll see. Clay, any last takeaways from you?
Yeah, if anyone who's listening is at all confused by this or has a bunch of questions, which is possible, we are going to continue to provide updates through our e-news on our website. I'm sure we'll do another podcast around these topics at some point in time, and if it is to the point that there's enough questions, maybe we can do a live Q&A thing on YouTube or whatever, but we will continue to provide updates and information along the way.
We just ask if we need to always encourage folks to be members of the Kentucky Pharmacists Association. If we've seen some listeners in other states, so if you're in another state, be sure to join your state pharmacy association so that folks like the three of us can take a Wednesday afternoon to review this policy and provide some input. So it's an honor to serve the profession and just ask for people's support and membership, and I appreciate everybody listening today.